So IV push, I'm not going to go in depth to it because there's a really good in your module. If I can find it. Just after your TPN. Oh, this is what a TPN form looks like. Ah, look it. So, and it's going to tell you, like your amino acids, how much, your dextrose, how much, your lipids, all this stuff. So the docs fill this paper out. This goes to pharmacy. You'll get this back from pharmacy with the bag with this label, and they should all match. All right, so you can look at that if you want. And then there's your IV push. It's 2 pages. I highly recommend that you review it. Okay? It talks about, basically we give it. Why do we give IV push medicines? When do we want them to work? We need it now, right? So it's a method used to administer a bolus dose, and we do it fast. So we want to make sure important factors. It talks about the rind, the rate, and compatibilities, normal dose, dilutants, what equipment you need, the procedure. Basically all I would do is read you this, which I think you all are competent to read it to yourself, okay? So if you have any confusion with it, don't hesitate to text me and ask me questions, but it's pretty straightforward. All right, so finally we get to CVADs, which is what we've been talking about. I promise we're almost done, y'all. Home stretch. Whew. All right, so these are a catheter placed in a large blood vessel for people who require frequent or special access to a vascular system. So there's lots of different ways central catheters are used. So we can do it peripherally. Oh, I just ripped it out. There we go. It can be peripheral, that goes up to the superior vena cava. It can be tunneled. It can be non-tunneled. It can be. We're going to talk about all the different types. Okay. They are typically placed by a physician or a specialized nurse. And these are the types. I'm going to talk about each of them, so it's okay. There's centrally inserted, peripherally inserted, or implanted. So peripheral, central, they normally actually kind of make an incision and insert it. And then implanted is where you actually have a port that sits underneath the skin. It feels slimy. So why do we use this? Because they need a lot of infusions or they need a lot of lab work, and it's really mean to keep poking these patients. Also, it's really nice because there are a ton of drugs that are vesicants, which I never ever use that word, but it is a key term, so I included it in. So it's a key term in your module, so I put it. Basically, they form blisters. So there are meds that you give when you put them in the IV that could leak out and cause blisters. We give them for blood and what we just talked about, PN. We can do hemodynamic monitoring with them. Or if a patient just has really crappy peripheral vascular access and they need long-term. So what are the advantages and disadvantages? 1, you have immediate access. You have less sticks, less risk of it leaking out, the medicine leaking out into that space. But a disadvantage is you have a really higher risk of systemic infection. So if you don't do dressing changes correct, you can put this patient at risk. It's a very invasive procedure, much more than a peripheral stick, but it's a one-time thing. So more invasive one time or a bunch of little sticks. Kind of rule the risk and benefits of it. So we said there was different kinds, right? So centrally inserted, they can be tunneled or non-tunneled. So does it? Oh, it doesn't get bigger. I tried. When I do it, it gets bigger. So tunneled or non-tunneled. So if it's tunneled, they typically start lower. I know I can't make it bigger. I'm sorry. So tunneled, they start lower and they just, what it says, they tunnel that underneath the skin until they make typically 2 incisions and they tunnel it and then thread it into the superior vena cava. So it's inserted into a vein or neck or chest or groin with the tip resting in that distal end of the superior vena cava, just like when I drew that picture before. And the other end is either tunneled or not tunneled. So they'll make the incision here. Okay, so they'll make the incision and they take their little tube, they make the incision and they kind of put it into the superior vena cava. They'll either leave it out like that, non-tunneled, or they'll put it under the skin like this one is, and it will be tunneled. Does that make sense? So there'll be 2 little incisions. Yeah. So they have the tubing. They're going to make an incision, cut into the superior vena cava, thread it in so that it's sitting right at the distal portion, right before you get to the atrium, the right atrium. Just want to make sure I'm saying it right. And then they'll either leave it just as is, which is non-tunneled, or they'll put it through the skin, which is tunneled. Okay?
What's the reason for the 2 different
Preference, how long they're going to have it. Huh? Oh, there you go. Tunnel can stay in longer. So often they have this Dacron cuff, which they can't, I don't know if you all can, this weirdo arm. Can you kind of see this little like lip right there? Can everyone see it? Here I come with my arm. Does everyone see right here? Okay. Everyone kind of see the little cup that's right there? Alright. You see right there. Cup. You see right, you can kind of see how it jets out a little bit more. Okay. My bad. You can see the little cuff. Okay. Can you all see it? The little cuff. Okay. So that's called a Dacron cuff, and it helps stabilize. So what will happen is it's like kind of like a cotton volley. When I used to insert them, they looked like. Have you ever seen the things that you used as a kid where you have a shape and you have pegs that stick up and you stick the little tubey things on top and you can iron it and it makes it, you know what I'm talking about?
like a shrinkity?
Yeah. So they're like little tubes with like a cuff on it. Like it's like kind of like fur or a cotton ball on it. And when they stick it in, we develop scar tissue around it. So they have this little cuff, and scar tissue kind of forms all around it, and it stabilizes it. Because if it's just the tube is this slippery little thing that can go in and out, in and out, in and out. This thing stinks. So I felt like I was doing something inappropriate there for a minute. So the tube can, it's slippery and it can go, but that cuff kind of stabilizes it and causes some friction so that it can't move as easily. And then scar tissue will form around it and kind of lock it into place. So when they get it removed, we actually have to cut in there, and then we use scissors and actually have to cut the scar tissue away from that cuff in order to remove the tubing. The rest of the tubing will come out fine. All right, so it can have anywhere from 1 to 4 lumens. So you see a bunch of 1 lumens here, right? And then you have 2 lumens here, 2 lumens. They have 3, 4. I guess we don't have that. Remember, we have funding issues. So, and different examples are like a Broviac or a Grosshorn. And the I'm not even saying that probably right, but it has a valve that opens as fluid is withdrawn or infused, but that valve remains closed when you're not using it. Okay, so those are, those are the centrally inserted catheters. The peripheral inserted catheters, like we talked about, there's a lot of writing, take a breath. They're write only what you need to, okay? Or come back and visit. So they are peripherally inserted. So they come in through like an arm. They're not going directly into that, superior vena cava. They're coming into a vein in the arm and then getting threaded all the way to the superior vena cava, okay? So we advance it so the tip still ends up in the distal portion of the SVC. It can be singled or multi-lumen, just like the central catheter. And it can be up to 60 centimeters in length. So does everyone see like the little blippies, the little black marks? Okay, does everyone see those little blippies? Everyone see the little blippies, the little black marks on there? Okay, so those are centimeter marks. This is really important when doing a PICC line, because when you take a PICC out, it's going to tell you how much it was inserted into, 40 centimeters, 25 centimeters, whatever. You want to make sure that when you take it out, it matches, because if it doesn't, you've left part of your tubing in your patient's body, and then they have to go in and surgically remove it, okay? So it's marked up to 60 centimeters. They're usually used anywhere from a week to 6 months. And it's really important, as you as nurses, you cannot use blood pressure or stick IVs if they have a PICC line in that arm. So, and there'll typically be a sign above their bed. If there's not, and you come into shift, and you've gotten in your report that you have a PICC line, and you walk in the room and you do your 60-second situational, and you don't see a sign, that's the first thing I would do, is go get a sign to put above the bed so your tech doesn't accidentally take the blood pressure. Because what's the tech's first thing they're going to do? They're going to walk in and take the blood pressure. All right? So no blood pressures, no IV sticks in the line where the PICC is. It has a little bit less infection rate, a little less insertion complications. This is where a specialized RN, with those centrally catheters that we just talked about in the last slide, those are all physician putting them in. This, a nurse can put it on the bedside. Now, she or he, has been trained. And they have some of the same complications. The cap can be occluded. You could get some phlebitis. It doesn't happen very often, but obviously it happened enough that we teach about it. I mean, I don't have a percentage, but most of the time there's not an issue. The big thing is when you're removing it, if you meet resistance, don't be like yank it out. You want to take a minute, okay? All right. So then the third thing that we talked about was the implanted infusion port. So that's this one right here. Okay? That's that port that's inside. So again, it's going to be, they're going to actually make an incision. They're going to open up. They're going to put the port, thread the port into the vein. Then they're going to close the skin over the port. And you actually have this kind of sitting underneath the skin. And you'll see on the patient like a little bump. It can be single or double. All right. So it's connected to this. So again, it's a central venous catheter that's connected to a port. And again, it can be single like you see right here, or double, which is just 2 of those. And when you guys are done with class, if you want to come up and look, it's kind of squishy in the middle. I don't know if you can see the squishiness of it. That's where your needle goes, and then it's protected by the hard plastic. So they access it by using something called a Huber needle. So this is a Huber needle without the needle. Just the catheter part. But this is what a Huber needle would look like. So everyone see it? I'm doing my best Dana today. Oh, my thighs can't take that. Everyone see it? Okay. All right, so what they'll do is they'll take this needle, and from the outside, oh God. Oh my God, no, I can get that.
Before y'all leave, I need to see, we're done.
my
I need to
Lanta.
see, Browers and the Cage group. These have to be filled out today.
Okay.
Pretty smart.
Okay. I'll try to finish up so we don't keep you anymore. Ooh, that hurt. Okay. So you're going to take the Huber needle, and where the squishy part is, you then stick that needle right into that squishy part, and you just right into it, okay? Then it sits kind of flush over the skin. You typically then tape it on, and then this gets connected to your IV tubing or your blood draws.
They leave that in, right?
The Huber needle only during therapy. And then when therapy's done, they take it out and the patient goes home. It's used a lot with chemo patients or anything like that.
It doesn't get in the hospital, though, will they leave that in?
Sometimes, but remember that's a direct access to your heart. So your increased risk of infection, right? So we have to be careful, and it's aseptically done. So when they do is they put the drug and it goes into that little reservoir. Yes.
The port itself is permanent though, right?
It's permanent. It will stay for as long as the person needs treatment. So some people need it for a long time. They put ports in typically for chemo. Like my aunt has breast cancer right now, so she has a port in. She's had it in for a year. She'll probably have it in for another year. But as soon as treatment's done, we take them out. They have to be in remission first. There is criteria, and they have to be like released. So typically, like when I worked for surgery, the oncologist would send us a note and say that this patient's central catheter is no longer needed. They've been in remission for 3 months or 6 months. And then we would go ahead and schedule surgery to get it removed. So it's not permanent, but it stays for quite a bit of time. Yes.
So how often will you replace the Huber needle?
Every time you do drug therapy. So what they'll do is they'll put Emla cream or some kind of numbing on top of the area because you feel it in the skin. It's very, I mean, you have a bump. This one doesn't do as good of a job of showing. It's so thick. But like normally it's like you see that bump sticking out. And so you can feel the squishiness from outside. So you'll feel around, feel the squishiness, put the Emla cream, let that sit for 30 minutes, wipe it, and then stick the Huber needle in. And then when you put the drugs in, or the medicine, or whatever, the medicine sits in that reservoir and then slowly gets distributed. Okay, so again, it's used for long-term therapy. It has a lower risk of infection. It has some cosmetic advantages. So for someone who's, walking around, you can't really see anything from the outside. But this, is more, I mean, this would get caught. It would be kind of annoying hanging there. Regular flushing is required because you want to avoid any sludge. And typically they do that by that, push that, little... I'm gonna... All right. So, this has a lot of writing. I would come back to it, okay? These are all the things that can happen. Your cath can become occluded, right? You have an embolism. You get infection. You get a pneumothorax. You have the catheter, it migrates. This is all the things we talked about. Why it happens is in purple. So you get a cath inclusion secondary to someone clamped it. It got kinked. The tip is against the vessel wall. What are clinical manifestations? You can't use it, right? It's slug. You try to push meds in, it gets stuck. The blue is the treatment. How do we treat it? We change the patient's position. We raise their arm. We flush it. The embolism, it's typically because the catheter breaks or a thrombus gets dislodged. So if a thrombus gets dislodged, which is the most common cause, then you get, what are some symptoms of an embolism? Shortness of breath, chest pain. So we treat them. We call the PCP because this is a medical emergency. But we go ahead and clamp it because we don't want to push any more air or fluid, right? clamp it, give them some oxygen. Infection, I think we've talked about a lot. If we're concerned about infection and they have any, we've talked to you guys, said all the signs and symptoms. We'd get a culture, we call the doc, all that. Pneumothorax, that's typically done during insertion, or typically occurs during insertion. So, you know, we're right here, the heart's right here, the lungs aren't far away. We're inserting this catheter in here, we might puncture a lung. And we're going to talk more about pneumothorax when we go to test 3. And catheter migration, that's if this Dacron cough has, if it hasn't had time to settle in and really develop some scar tissue or hasn't been sutured in correctly, it can migrate. So this is where you'll see if the catheter goes too far, then you'll see dysrhythmias, or you'll see, or it could just fall out too, and then it's not in the right placement. So a lot of times what can happen to your PICC is your PICC becomes a really fancy, expensive peripheral IV. So, because it's left the superior vena cava and it's kind of migrated out. So, all right. So, nursing management, we talked about this. I'm just going to finish up because it's only 2 more slides, okay, guys? Then we can do some cahoots on Thursday and do some review of all this material before we go to our pain and palliative care lectures. So nursing management, obviously we check X-ray again. We want to confirm the placement. We inspect it. We assess it. Dressing changes are always per policy. Every place has their own different policy. But we really need to make sure you use strict sterile technique. Change injection caps at regular intervals. Those are those little blue caps that you guys see. Patient, when you patient can turn their head to the opposite side and kind of bear down to prevent an air embolism. And they use that push pause technique to flush to kind of create turbulence. So remember we talked about we have to, especially with the implanted ones, we need to flush them regularly so that, because they store in their reservoir drugs, right? So if they're storing stuff in there and it's just sitting there all the time and we're not doing anything with it, then it could, you know, get clogged or clotted up. So in order to kind of create some turbulence in there, we use the push pause. We just push pause, so that you can kind of make sure you get everything out. And then removing them. So obviously, if there's any sutures, remove those first. I have seen residents just try to rip out the CVAD with the suture still in. So make sure that you get a suture. So we as the nurses, you'll see, I mean, they're pretty easy to remove. But make sure you as the nurse, you come prepared. If the doctor's written an order that they're going to come remove it, then get your suture removal kit to the bedside. Get your sterile gloves to the bedside. Why the patient performs, they're going to bear down. So you're going to kind of withdraw it while they're bearing down. You apply pressure immediately to prevent any bleeding. You want to inspect the tip, like I said, to make sure that it's all intact. And if it says that it was inserted to 40, that I have 240. And then after bleeding is stopped, you can put a little ointment in a sterile dressing. Typically what we do is you'll get everything ready and you'll put the little gauze and a clear opsite on top of it right away, and you tell them to leave that for a day or two, and then take it off, and it should be, you put it hard enough so it's got some pressure to it. So I know I kind of zipped through the end of that. But we got everything covered. All right. Do you have any questions about any of that? Did it make sense? Okay. Clinical manifestations.